Okay. Yeah, there's a lot of these.
Can't get rid of it.
So we do have some new fractures, bimalleolar, trimalleolar. We have a sprained joint injury for the foot, Schlatter, Osteomalacia, right? Those are kind of our new ones. Everything else we've already sort of seen. As far as tumors go, right, a lot of these are the same as well. Right? Did throw in metastatic carcinoma here.
You put that on the test as well?
I did, even though it's, we already kind of discussed that. These two are really the big new ones. I mean, in this case, it's a giant new one that we have coming up as far as benign goes. So, kind of, half of this is going to be pretty much like a review of the previous chapter. Now, to talk about this, we do need to go over some lower extremity anatomy, because I don't believe you've gone over this with Mr. Donahue yet, correct? Okay. So, foot. Foot is a lot like the hand. You've got 14 phalanges. You've got 5 things beyond the phalanges. That's right. In the hand you have metacarpals, and the foot is metatarsals. Not too bad so far, right? So down here, instead of 8 carpals, we have 7 tarsals. That's right. If we have metatarsals, we also have regular tarsals. So you've got 7 tarsals here. The big one is pretty famous, the calcaneus, right, the heel bone.
Oh, that's the one they take a lot of X-rays.
Yep, that's right. So we do have X-rays specifically for the calcaneus. Above the calcaneus is a bone called the talus. This is the bone that connects the foot to the leg, right? So it's part of the ankle.
You said that was what?
The bone, the talus, is what connects the foot to the rest of the leg. So this is going to be part of our ankle joint, the talus. Oh, I'm sorry, I forgot to turn on the TVs. Distal to calcaneus and talus. On the medial side, we have the navicular, kind of a longish bone going crosswise.
I've seen that word before.
Yeah, it's the other name for scaphoid.
It is the other name for scaphoid as well, so please don't get them mixed up. But if you think about it, right, scaphoid is also kind of a longish, curved-ish bone, so similar shape, similar name, navicular. And then finally, we have these 4 bones here, going from medial to lateral. On the medial side, we first have the medial cuneiform. Okay? The medial cuneiform connects to the first metatarsal. We have the intermediate cuneiform. This connects to the second metatarsal. We have the lateral cuneiform. This connects to the third metatarsal. Notice that even though it's called lateral cuneiform, it is in the middle of the foot. It's called lateral because of the 3 cuneiforms, this is the most lateral one. But it does not mean it's on the lateral side of the foot. Just that it's the most lateral of the 3 cuneiforms. The bone that is actually on the lateral side of the foot is the cuboid. Cuboid looks kind of like a square or a cube, which is why it's called the cuboid. And that connects to the 4th and 5th metatarsals. Okay. So really, the tarsals are the only kind of weird thing here. Everything else looks a lot like your hand, right? Your metatarsals instead of carpals, and then your phalanges. Right? First phalange still only has 2, right? Proximal and distal. All the other phalanges have 3. One more piece of anatomy that we need to pay attention to. Let me make sure I'm on the correct. Do I not have a thing of the? One second.
That's tricky.
Right, something deeper. All right. Anyway, sorry about that. Okay. Sorry. Okay. Great.
That's what you're saying.
All right. So, over here we have our tibia and fibula, right? So this is the lower leg. So as far as the tibia and fibula are concerned, tibia is the big one. This is the weight-bearing bone. Fibula is the small one. Remember, it is tibia and fibula. It's not tibia and fibia. It's not tibula and fibula. It's tibia and fibula, right?
Wait, what's fibula?
Fibula is this small, thin one. So tibia is medial. Fibula is lateral. Okay, so tibia is this big weight-bearing bone right here that you can feel, right? If your shin, right? That's your tibia. And then fibula is off here to the side. It's lateral and it's slightly posterior to the tibia. You can see it's posterior on this image as well, right? You see how it's kind of like hidden behind the tibia here? It's kind of hidden behind the tibia.
So you said the tibia was weight bearing. What is the fibula? Is it
It's
for
just there.
support?
Yeah, it's just support.
So we can function without it?
You said punch?
No.
Function.
Oh, function.
No, you cannot function without the fibula. And the reason for that is because of the ankle joint down here. So the ankle joint, if we look down here, so if we look at the distal tibia and we look at the distal fibula, you'll notice that we have two important structures. These two bumps right here. Right? On the radius and ulna, what do we call these? Styloid process. Too bad, it's not called the styloid on these bones. Instead, we have a new name, the malleoli. Yes. So we have the malleoli of the tibia, which is the medial malleolus. We have the malleoli of the fibula, which is the lateral malleolus. Which makes sense, right? Because tibia is medial, and this malleolus is even more medial. So this is the medial malleolus. And then for the fibula, it's lateral, so it's the lateral malleolus. There is actually a third malleolus as well that you can't really see on this image. And it is the posterior malleolus. So there are actually three malleoli. Have you seen the term malleoli before? Where? Have you seen the term malleoli before?
Fractures?
What kind of fractures do we have? Bi meaning
Two.
two, and tri meaning.
Three.
That's right.
Oh, look at you.
So, bimalleolar, trimalleolar, right? Either we break two of these malleoli, or we break all three of these malleoli. Okay, so very important.
So where's the third one at?
Posterior.
It's
Oh,
posterior.
posterior, yeah.
Yep, so it's somewhere back here. It's just unlabeled on this one. Can you break just one? Yeah, you can break just one. In that case, I don't have a name for it, but you would do something like an ankle stress view to check something like that. What is that in the middle? What in the middle?
Like the cavity kind of thing?
Like this? This stuff? Oh, I mean, so this is kind of like how you have the space between your radius and ulna, and then you've just got some tissue, some connective tissue there in between the two bones. For us, we don't really care about the connective tissue since we're more interested in the bony structures. So don't worry about that. I mean, you do have bone cancers, so it is what it is. Yes.
Are those ankle athletes like bimalleolar, trimalleolar fractures? Are those more common with athletes or like?
Are they more common with athletes?
Like basketball players breaking their ankles or football players?
I don't have the numbers, but I would not be surprised if that was true. For example, with orthopedics, if you do talk to any of those orthopedic residents in surgery, a great number of them are looking to go from orthopedics and specialize in sports medicine. So they probably would handle a lot of stuff like that. Okay, just a few more things to make note of here on the tibia fibula. Up top here we have the tibial tuberosity, right? Just like how you have the radial tuberosity on the radius. So this tibial tuberosity does connect to a ligament that goes over the patella. And we'll talk a bit about issues with that in just a moment. Yes, John.
What is that line on the second one? It's kind of similar to anatomical neck.
Which,
On the tibia, yeah. Well, you were just pointing at it.
over here?
Little bottom. It's like the neck part.
Oh, the.
Yeah, right there.
This kind of thing here, this ridge.
Uh-huh.
Great question. I don't remember. My best advice: check your mirrors. Okay, but are we kind of okay with the general structure of the lower extremities here? I do have one more picture here to take a look specifically at that ankle. Right, so remember, this is our talus. The talus is the tarsal bone that connects to our leg bones, the tibia and the fibula, right? So this is the tarsal bone that is most superior. Oof. Right, this is the tarsal bone that is most superior. Okay, and then it articulates with both the tibia and the fibula. So fibula, lateral malleolus, tibia, medial malleolus, tibia, also posterior malleolus, right? 3 malleoli. All right, so let's talk about the fun stuff first. Fractures. So our first one is the pot fracture. This is a bimalleolar ankle fracture. So 2 malleoli are fractured. It is going to be a fracture of the distal fibula. So which malleolus is this? So fibula only has 1 malleolus, and it is the lateral. So remember, fibula is lateral, it's the lateral bone, so it has the lateral malleolus. Okay, and then we also have a fracture of the distal tibia, which is the medial malleolus. So in a bimalleolar fracture, we're looking at fractures of the 2 malleoli, medial and lateral.
Is this the only bimalleolar fracture that we're going over?
The only one that we're going over, yes.
So did you say medial was what and lateral was what, sir?
Medial is tibia.
So medial, right? This is the medial malleolus, so it's a fracture of the tibia. And over here, we have lateral, so it's a fracture of the fibula. So here's our fracture of the medial malleolus. Here is our fracture of the lateral malleolus. Right here, and then right here. And so this is major damage to the ankle joint because you're supposed to have ligaments here holding things in place. Now that the bone is fractured here, the ligaments aren't really holding on to anything anymore, right? Because now it's no longer connected. So the ankle joint is compromised. This does require surgery. If you go into surgery and the case is an ORIF of the ankle, and what does ORIF stand for? We did talk about this.
What is it?
ORIF of the ankle.
Open reduction.
Yes, the OR is open reduction.
Internal rotation.
Internal
Fixation.
fixation. ORIF.
Oh, girl.
Reduction internal fixation. Great
Something
job.
is sparking.
Yes,
So if you go to surgery,
You know
right?
something, huh? Nothing.
And they cut open the ankle and they begin putting plates here on the ankle, and they start putting screws all along here. And they start putting screws up here. That is because it is a malleolar fracture. Right? It does require surgery most of the time.
I think Nicole has that.
Okay, and then sometimes we have our trimalleolar fractures. So now, not only do we have a fracture here of the medial and the lateral malleoli, right? So the tibia and the fibula, but we also have a fracture of the posterior tibia as well, posterior malleolus. So 1, 2, 3, that is your trimalleolar fracture.
So we can only see the posterior malleoli if they're in a lateral?
Right, so it's best visualized on a lateral. For your bimalleolar, right, you can see them both on your AP ankles. But for your tri, you need the APs and the lateral.
So, do you usually take 3 views whenever you do ankles anyways? So
Yes.
just in case?
Yes, very good. So ideally, you would do 3 shots of the ankle, just like you do with the hand. AP, oblique, lateral. Sometimes if it's trauma, you can only get AP and lateral. But at the very least, you should have 2 views so that you can check for something like this, right? Fractured here on the posterior. We look here, right? Lateral, no fracture, right? That's why this is only a bimalleolar. This is not a trimalleolar. Right? No fracture here on your bi, but you do have a fracture here on your tri. So far, so good? We're okay with the malleoli?
How would you do
An oblique ankle?
ankle?
So if you imagine this is the left ankle, right? This is the big toe. You would do an AP like this, and then you would oblique it in this direction. By doing that, you are supposed to open up this joint space here. Right? Notice on the AP, this joint space is closed. When you oblique it internally, that opens up this joint space, and you can see the entire joint space around the talus. You'll learn about this later. It is called your ankle mortise. You're looking at the mortise joint around the talus.
Are there any other names for the trimalleolar?
Oh, you mean like how bimalleolar had pot?
This one says cotton.
This one says cotton?
Down at the source.
It does say cotton fracture. I'm not gonna worry about that. Good item. Okay, so yes, so I'm just gonna call this trimalleolar fracture. Alright. I forgot to add this onto the list. Hold on.
What was the pot fracture then, sir?
Bimalleolar.
Biman.
Did you write
Yeah,
that?
I did.
Yeah.
Alright, and then we also have the stellate fracture.
This one's different.
So, stellate fracture, right? Stell, like Stella, right? Stellar, star. Okay, so stellate means, or it sounds like star. So the fracture looks like a star, right? The fracture radiates out like a star. It looks like a star pattern. Does that make sense? You know, like how,
It's like Patrick.
Bro.
yeah, like Patrick from SpongeBob, right? Or, you know, like how kids like to draw stars, they're like, right here, that's a star, right? And now you just imagine that this is on a bone, right? And that's how it fractures.
What are you talking? We don't see it.
Oh, you don't see anything. Oh. I forgot to share. Okay, right. Okay, thank you.
I thought we were like not supposed to
Dude, for a
imagine.
second, my 2 brain cells were going brrr.
All right. So, right, like a kid would draw a star like this, right?
What?
An asterisk?
Yeah, like an asterisk, right?
Okay.
Right, so
Still how it
looks like a
goes,
star, right?
What are you trying to say?
And then you just got this is inside a bowl, right? And that's your stellate tract. Like it just spreads out like the star pattern.
Okay, now I gotta see it on the picture.
Right, so just spreads out like the star pattern.
Okay. I see
So is that an
it.
impact fracture or?
So yeah, it's like the patella slamming against something from the front. So this most happens with the patella, right? Kneecap. So kneecap comes in and like slams against something, right? And it shatters like this, right? And when it shatters, it splinters in all these directions. So in this case, kind of like that.
So is
So
Yes.
trauma
painful.
view? Like trauma views and all that?
So yes, we do have views of the patella. If the patella is fractured, please be careful and do not flex, do not bend the patient's leg more than necessary. Right? So a little bit of bending, a little bit of flexion is okay, but try not to bend the patient's leg too much if there is a patellar fracture.
what about extension?
Extension is usually okay. Right, usually the patient is most comfortable in extension. But when you flex, you're putting pressure on the patella because it tries to sink into the joint space.
Wait, in that X-ray picture, is it like
Yes.
It's a
a
neat-
hairline, or is it like?
No, this is completely broken all the way through.
Oh, it's so hard to see. I would have not
Yeah.
noticed without the arrows.
It's- So yeah, it can be tough to see, right? So when you do shoot a knee X-ray, right? First thing you do is, all right, I'm gonna look at this patella, and it's like, all right, is the patella in the middle? If it's in the middle, I know I have a pretty good AP. But while you're doing that, also take a look and see if you notice anything like this, because you see like there's this fragment up here, there's this fragment over here, there's this fragment down here, there's this fragment right here, tiny fragment here in the middle. If you see that, then you're like, oh no, this thing's broken. I'm gonna be very careful with the patient for the rest of these X-rays.
Doesn't
Yes.
doesn't this patella look like the humerus at the bottom portion?
Yeah, it looks a bit like the humerus at the bottom, right? It almost looks like you've got, like your
Elbow.
reticulum, you've got your trochlea, you've got your epicondyles, but it's not, right? Instead, what you have, you've got your femoral condyles, and you've got your femoral, epicondyles up here. And then down, you've got your patella, and you've got your tibial plateau with the intercondylar eminence.
So no olecranon?
Heard you.
No
Don't try
lectinum.
that.
Yes, and then you've got your fossa right here.
The patella would be.
But yes, this
like
is a
the-
stellate fracture.
Mhm.
Okay, basically the patella shatters, and you can see it shatter into kind of like these peaks, this star-like web of lines. Yes.
Can someone have a stellate fracture and then have an avulsion fracture on top of that? Like it gets pulled away from.
No, because, sorry, if you're just talking about this, then most likely not, because of stellate fracture fractures because of that impact, right? An avulsion fracture would be fracturing because there's something here attached to the patella that pulled a piece off. If it's already shattered, then it's not going to be pulled off due to an avulsion. It's already broken.
Okay.
Can you go from avulsion to stellate? Maybe, but at that point it doesn't really make a difference because everything's broken at that point.
What is that? That's the bone pattern inside?
So this is the patella. So this bone is on top of the femur.
Like your kneecap.
It looks really tough.
So basically, you've got the femur like this. You've got the patella sitting on top like this. And this patella is basically broken into like 6 pieces or 5 pieces. Right here on top of the femur.
They do look like that too.
So if you take a
You're
lateral
saying
of
like a
it,
broken cookie. See?
So it is.
Yeah, look at it.
Like this fragment right here.
So
You
what's
see
a
the line?
broken
You know how you get a cookie and you break it and it kind of starts crumbling?
yeah.
Like that's what it looked like to me.
Why is that so accurate?
And she said, I was like, yeah.
You see how it looks dark right here?
I see that, I see
You see how it looks dark here?
No, it's not.
You see how it looks dark here? How it kind of like branches off?
During
See all
patient
these
care, she's
lines
like,
are these white pieces, right? So those are the pieces of the bone. So you've got one big piece here that's about half the patella, and you've got all these other small pieces.
So Mr. Phung, if you do a lateral,
Yes.
is it gonna be like posterior, anterior?
So yes, if you do a lateral, you'll be able to see if the pieces move posterior, interior. We may also sometimes do a sunrise view as well.
But they can't.
Yeah.
They can't
but
flex their knees.
how?
So it will be minimal flexure.
So that's like I need you to do as much as you can.
Or you just like take the knee?
Dude,
Sunrise view with minimum flexion.
Yeah.
Maybe
Yeah.
Yeah,
It's never
no,
easy.
don't force them to this.
Right. But no, yeah, normally it would just be AP and lateral. Normally for something like this, it's just AP and lateral. And then for surgery, all they do is they take some metal wires and they just kind of like bind it back together.
That's it?
Yeah, and maybe I think maybe they'll sometimes put like 2 screws down those sides.
They don't replace it for these things?
No, you just put it back together.
no, they just rig it.
You know, just,
Hope it works.
just get some glue, put the pieces back together.
That's
Like
it.
when you break your mother's face or something.
What?
Whoa.
That sounds like.
I mean, that's what you see in TV shows, right? It breaks the mother's face and then like, oh no, and then you like get the gorilla glue or whatever and they're trying to put it back together.
Oh my God! You said vase.
Not face.
Oh, not
Oh, it's like, yo, what kind of TV are you watching?
I heard face too.
flower vase.
Okay.
Oh, that sounds better.
Dude, I was like, this is violent, bro.
I thought you said face.
Are you talking about experience?
Yeah,
Okay, so don't piss
They
him
put
off.
somebody's
My
face
accent.
together.
That's why I was gonna say the actor, he killed his mom, his parents. Because when you said the face, I was like, man, that actor, he's a young guy. He killed his parents. He just got convicted. I don't know what was that movie he. Or
What
the
movie?
I have not heard about this.
Yeah, he was.
Well, what is that? The actors and you put it in a vase and you break it and then put it. I see that in movies too.
Oh, yeah, like when
They
you
usually put those ashes in the vase.
well, yeah, like after a cremation.
Break.
Oh yeah. Mm-hmm.
Oh.
All right, so are we okay with Stelly?
Yes.
Kind of understand how that works?
Yes.
All right, great. So over here we've got some more bone cysts, right? We talked about these before, right? They look more radiolucent than the bone around them, but they have these nice, clear borders, right? Bone cysts right there. Right. We also have gout. Okay, so this is gout of the lower extremities. So once again, affects the joints. Usually third MTP is going to be where it starts.
And it's still uric acid.
Still uric acid. Over, right, so in these pictures, right, you can maybe like see some of that swelling here. You can see some of that swelling here in these joint spaces,
I
right?
thought that was bursitis.
So yeah, so you've got the gout here, and then it's caused inflammation there.
So it's basically infection of the joints,
Infect?
gout, is gout, disformation of the joint.
It's when uric acid builds up inside the joint spaces.
How do you differentiate between gout and bursitis?
The bone is like degraded.
Well, radiographically,
Yeah.
um,
What is it?
it's a good question.
The bone looks
So,
degraded.
so yeah, bone does look a bit weird on gout, right? Compared to something like bursitis. But really it's just gonna look up, you're gonna see that weird bone stuff, so that can tip you off the gout. But you're also gonna see tissue swelling, and I mean tissue swelling is just tissue swelling. it's going to be really hard to pinpoint if it's going to be like bursitis or fusion or anything else specific. So yes, don't worry too much about that. Yes, Samantha.
Just something to kind of add on this, because I know we've seen it a little bit last time. I actually worked with somebody, probably back in the day. They were really young. They were actually only like in their mid-20s when they actually got it. And this X-ray is interesting because they had it on their big toe as well.
Mm-hmm.
And they just did the weirdest thing. They just said they could not move their big toe for anything. It hurt. It couldn't bend. They said it was super stiff. It
Mhm.
couldn't bend, and they thought they might have broke the toe. And so when they went in to a clinic or whatever, they were telling me that they just expected maybe they hit it. They don't know what happened. It was super painful. Didn't know what's up.
Mhm.
Then they were told it was this,
It was gone.
and they said it went away. I guess in a
Mhm.
couple days or whatever it was, a few days.
Yeah.
Yeah.
A
And they were
gout
young
was
and
a-
average weight.
Yeah. So with gout,
You gotta go to-
easiest way to manage it is to manage your diet. Right? Eat things that are going to be low in purines, things that are not going to produce a lot of uric acid.
My dad said like even like the fan blowing on it like made it hurt.
Mhm. Yes. Gout is painful.
So low in purine, you said? Low
Yeah.
in
Yeah. Things like purines.
purines are what?
How far should I go into this?
As deep as possible.
So just like, is
So,
it a
so purines are a class of chemicals. Purines are most famous for being a type of building block in DNA. Because in DNA we have purines and we have pyrimides. So
Alright,
your
those two words.
purines, if I remember correctly, are guanine and cytosine, and I think your pyrimidines are adenine and thymine, right?
He started it.
But yeah, if you have, for example, certain fish will have a lot of purines in them. So, like for example, my dad suffers from mild gout, so we make sure to avoid specific types of fish, right? So that it doesn't cause a flare up.
Makes sense to you?
Yeah.
You got it?
So what is myocardium?
What?
Mild.
Not severe. So it just has a
Mild.
little bit. But also, right, drinking a lot of fluids, make sure to get rid of the urea through the kidneys, right? Rather than giving it time to deposit in the joints. That also helps as well. I'm not it's just because my dad has got that. I'm actually familiar. I don't.
You are really smart.
I do not.
I like this.
If I don't know, though, there's always
Soften them up.
Wait, didn't we, who had a question that they said that Mr. Phung never got back to?
There are probably a few questions I never got back to. I'm sure there were.
A couple.
He was like, I'll get back to you.
I know
Never
there
did.
were. I know there were a couple that I never got back to. I don't remember them anymore. According to the hospital.
What happened to that list?
So, before we
that's
bully Mr. Phung any further, let's move on to some new pathologies.
Unfortunate.
So, here we have chondromalacia patella. So, chondro, what did we say this is? Cartilage, good. What does malacia mean?
I don't know, it sounds
I
bad.
don't know.
A country.
Yes, Jay.
Isn't it like something was degraded?
Close. Malacia means softening. So a softening of the cartilage. Which cartilage? That's right, the cartilage at the patella. Okay, so this is softening of the cartilage underneath the patella, between the patella and the femur. So there's supposed to be cartilage right here, but that cartilage has softened, and because it softens, it wears away. So the cartilage begins to go away, and now if you have patella against femur without that insulation of the cartilage, it becomes painful.
It's under or near?
It's under, so it's here, kind of like in between the patella and the femur. That's where the cartilage would be. So it's really hard to see this. You can't really see it under X-ray. You don't see cartilage under X-ray. But you can look for other things. So you can check for pathologies of the joint space. Does the joint space look narrower than normal? Or do we start to see joint effusion, do we start to see swelling in that area or where that soft tissue is? Right, bone to bone. In this case, we can kind of see this radiolucency. I believe the report said they suspected these were cysts that had formed due to chondromalacia patella. So we can't see the cartilage directly, but we can see the side effects of it disappearing. So we'll do AP and lateral knees exactly as we expect. We may also do views of the patellofemoral joint. So in this case, something like our sunrise view. Okay, are we okay with this one? Okay, another name for this is runner's knee, right? Because runners tend to wear out this cartilage. All right, now here's an interesting one. Lisfranc joint injury. So this deals with the foot. And the foot is very interesting because we don't actually have a ligament holding these two metatarsals together, right? So what keeps these two metatarsals from separating if nothing holds them together directly? Well, instead we have the Lisfranc ligament. This connects the second metatarsal to this medial cuneiform. Remember, the medial cuneiform is the most medial of your cuneiforms of your tarsals. So it comes diagonally like this. Right? Medial connects to the first, your intermediate connects to the second, but the ligament does not go straight, it goes diagonally across. So it goes from the second metatarsal over to the medial cuneiform. And because of this, it is putting pressure, it's putting tension, and that tension is what keeps these two bones together. So they're not actually physically held together, it's just that there's enough tension, there's enough force to hold them together instead.
And that's only for the second metatarsal?
Correct, that's only for second metatarsal. Second metatarsal to medial cuneiform. So the Lisfranc joint, right, covers this entire like carpal tarsal metatarsal area, right? So this is like this is your Lisfranc joint. But what we're most interested in is this area, because if this ligament tears, now there's nothing holding these two bones together anymore. And because nothing holds them together, you will see them separate. So this is what that looks like. Right? So here, right, nothing's holding them together. So we start to get a space here. Here, well, this isn't just a ligament issue, this is a complete fracture, right? So that's why the toes are all screwed up. But also, right, here to here, the ligament is no longer keeping these together. Okay, so you start to get this gap here that should not be there.
Does it make it
You must have stubbed
easier
it.
for any fractures when that ligament isn't there anymore, or?
Does it make it easier to fracture things without the ligament? I'm not sure about fractures, but it's definitely going to have a big impact on how you walk. Because now that you don't have anything holding this in place, as you're walking, this is going to like go medially like this, and that's not going to. That's not good. Definitely not going to be comfortable.
Can you go back one slide real quick?
So, because of this, one way that we can view the Lisfranc injuries is by doing weight-bearing foot X-rays. So, when you do lower extremities, near the end of this month, you'll learn that to do foot X-rays, you're going to lay your patient on the table, and they're just going to rest their foot on the table. But to demonstrate this, because we want to see the separation of the joints, we are going to have the patient standing on our IR for these X-rays. Instead of laying down, they're going to be standing up and they're going to be putting their weight onto their foot. That way, when the weight comes down, it forces these apart and we'll be able to see that gap. So we do weight-bearing X-rays of the foot. If we want to see the ligament itself, that's when we would turn to CT or MRI. Okay so far? Yes.
CT and MRI for what, Doctor?
To view the actual ligament. Remember, you cannot see tendons or ligaments on X-ray. Unless they're calcified. But that's something we're not going to worry about. Okay. Next up, we have Osgood Schlatter. So this is the one dealing with that tibial tuberosity we talked about at the beginning. So this is a lateral view of the leg. This is your proximal tibia. This is your distal femur. This is the patella. Here you've got a ligament that connects to the tibial tuberosity. However, in this case, what happens is that there's constant trauma to this region, constant pressure. So the ligament, right, keeps getting pulled or keeps getting damaged, and it becomes inflamed. And eventually, what happens is that, kind of like an avulsion fracture, it pulls off fragments of this tibial tuberosity. So we get this fragmentation of the tibial tuberosity. This is very common in kids, like teenagers, who are active, right? Because they do end up using their legs a lot.
So that was tibial tuberosity? Yeah.
So yes, done. This is the tibial tuberosity right here, and it has fragmented. So if we were to look at some images, right, if you look here, notice how this piece has basically come off here. Do you see that right there? Right, so the ligament comes down like this. It's supposed to attach to the tibial tuberosity here, but the tibial tuberosity has fragmented and pulled off. Right, it looks kind of like chipped in. Yes,
You
John.
said it's more common in children or boys?
Children, teenagers.
Because on the thought it said boys
Boys 10 to 15?
10 to 15.
Yep, boys 10 to 15. Okay. Yes.
So
Most common in boys 10 to 15. Because they do tend to be some of the most active.
never mind.
And over here, you can see the same thing. You see how this is fractured and fragmented? Right here? Right? This line, right, does not belong there. These pieces came off. So that is Osgood Schlatter.
And those are different than bone spurs because bone spurs aren't necessarily avulsion related.
Right, bone spurs are not fractured. They're just growths that come straight off the bone. Like these are actually pieces that are broken off.
Is this fracture to the bone and the cartilage?
Fracture to the bone, inflammation of the cartilage. few more. We'll make this our last one. Osteomalacia, also known, this is pretty short. Osteomalacia, also known as rickets. So, osteo, what does this mean? Malacia, what did we just say this is? So, softening of the bone, that's right. So this is softening of the bone, also known as rickets. This is what happens when there's a poor diet, right? Deficiency of certain minerals, and so the bones are now soft. And so because the bones are soft, they are bendy. So instead of being nice and straight, the tibia is now bent, it's curved. Do you see that? Even this fibula here is kind of curved, right? These bones should be straight, but they are bent. It creates this bowing, makes it look like they are bow-legged. Right? You have this just overall curve of the leg that should not be there. The leg should be straight under normal circumstances. So we do regular AP and lateral X-rays of this to take a look at the bones.
Is their left leg lateral? Like the ankles and foot look like they're...
It's debatable. It's kind of lateral.
like oblique?
Yeah, it's kind of oblique. So the more common name for osteomalacia is rickets. If you've ever heard of rickets, this is what it's referring to. Right. And then we have Reiter syndrome. This one, in my opinion, is kind of weird. I've forgotten exactly how this works, but somehow or another, patient starts off with an infection of the GI tract. And then somehow or another, that infection makes its way down to the heel. And then it causes this erosion here of the back upper part of the heel, like the posterior superior part of the heel. So normally the heel is supposed to be rounded like this. Right? But you see how it's kind of eaten away? Right? And this is where the Achilles tendon is supposed to connect to. Okay. So this is Reiter syndrome. In addition, it also affects the SI joints, and this is called reactive arthritis. Don't ask me how the GI tract infection makes its way down here. I have forgotten. I do not know.
Did you say it affects the back of the ankles?
This is the back and top of the calcaneus,
The heel.
the heel bone. By the way, what bone is this up here? The round bone? Talus, very good. All right. Osteoclastoma. All right, so osteo once again being bone, oma,
Tumors.
tumor, good. So osteoclastoma, giant cell tumors. These look a lot like something else, don't they?
Bone cyst.
Yeah, they look a lot like bone cysts. What's the difference?
Is
I
the
don't know, it's hard to say.
Is the shading there?
Here?
So
What is that?
the shading in the we didn't have that in yes.
So yeah, they don't look as radiolucent as bone cysts do they? So maybe that's one hint. But the idea is that they also look like bubbles, right? Just like your bone cysts. Okay. However, they only occur next to a joint space, right? So they only appear next to an articular surface. And only when the growth plate, right, the epiphyseal plate has closed. And also, these are off-center. but they're not going to be centered on the bone. They're going to be off to the side, or to the front or back, or something like that.
But
Yes.
just
Do we get these slides?
Wednesday, after I give you your vocab and turn it in.
is the exam for this gonna be after we learn upper or lower extremity?
With Mr. Donahue?
Mm-hmm.
No.
Oh.
Otherwise, I would have to wait until spring semester before I can give you your exam on the spine. I'm sorry. I'll try and be technical.
You're gonna need a lot of those questions.
So, just for this one, right, keep in mind that they show up as giant bubbles. That's their main signature. And we'll go ahead and stop there.
Good job.
Now that we
Yes.
have some time, dosimeters.
Yes, so I do have your dosimeters now. So, let's take your 15-minute break.
50?
15, 1-5.
Oh.
And when you come back, we'll start off by